Welcome to the Center for Global Development. My name is Javier Guzman, and I'm the Director of Global Health Policy and a Senior Fellow. It is a pleasure to have you all here for this event to celebrate a decade of health prioritization. We're launching the Health Systems and Reform special issue on priority setting. So a few words to get us started. First, we all know money is tight and policymakers need to make decisions. Health systems make decisions on what to cover, who is covered, and at what price things are covered. And that basically means defining priorities. That basically means defining how the money is going to be used. In 2013, the International Decision Support Initiative, or iDSI, was created to support countries make those decisions, was created to build institutions to support countries make those decisions. And in the past 10 years, iDSI has supported over 20 countries, improving institutions, improving decision-making, and improving, of course, the use of evidence to make decisions. That basically means spending the money more efficiently, more effectively, and more equitably. So here we are celebrating 10 years of work, and we are celebrating how we are putting together 10 years in a special issue of this Health Systems and Reform Journal. So I'll invite you all to check it out. We've got over 20 articles, lessons learned from different countries, lessons learned at the regional level, and even experiences from Latin America, Asia, and Africa, from countries that are not part of the iDSI network. So you will also have a very new, good project page where you will see some of the highlights of 10 years of work. But I wanted to summarize 6 lessons that we have learned in the past 10 years when supporting countries to strengthen their priority setting systems. The first one is priority setting institutions do produce a high return investment, so are good value for money. And you'll see an article on how that was measured in India, for instance. The second lesson is you need political will for these institutions to develop. So political will is essential. Third lesson is capacity is limited, and therefore it's important to deploy important interventions to maximize the use of that capacity. You'll hear and you'll see articles on topic selection, on adaptive health technology assessment, or regional collaborations. Number 4 is it's not just about making the decisions, it's also about implementing those decisions, so the importance of implementation. Number 5 is it's important to mobilize the national capacity because countries start at different points in time. So mobilizing what is there is extremely important, and linking what is there with regional networks will ensure and will increase the likelihood of long-term sustainability. And last but not least, the decisions that are made at the country level need to be aligned and need to be paired with decisions that are made by global health institutions. And that is, priority setting within the global health institutions such as Gavi, the Global Fund, etc. So with that, and without further ado, it is a pleasure for me to introduce a very good group of experts, esteemed panelists, who will be with us to discuss priority setting, to discuss lessons learned, and to tell us about the future, because it's not just about the past. So with me, I have Saudomini Dabak, who is head of the international unit of the Health Intervention and Technology Assessment Program, HITAP, at Thailand, within Thailand. Thank you very much for being here, Saudomini. We have Satoshi Esoe, who is the director of the Global Health Strategy Division at the Ministry of Foreign Affairs in Japan. Thank you very much for being with us. We have Justice Novignon, who is the new technical director for primary healthcare Efficiency, Effectiveness, and Equity at Management Sciences for Health. Is a new position, so congratulations, Justice. He used to be the head of the Health Economics and Financing Program at the Africa Centers for Disease Control. We also have Ursula Gideon, who is a non-resident fellow with us at the Center for Global Development. Thank you, Ursula. And last but not least, we have Mark Blecher, who is the Chief Director of Health and Social Development at the National Treasury in South Africa. So Mark, thank you for being with us. So we're going to get the conversation started with a few questions, and then our audience will also have the opportunity to ask questions. For our audience, please do submit your questions using the panel in the YouTube chat or using Slido or in the event webpage. We'll get your questions and then we'll ask our panelists what you have in mind. So Domini, I'll start with you first. I mean, you come from HITAP. HITAP was one of the founders of the iDSI network, and it's been around for 15 years. So one of the articles you published with your colleagues was about what you had learned during those 15 years. So can you tell us a bit about what are those lessons that are important to, building priority setting systems, especially in terms of political traction? Welcome and thank you.
Thank you so much, Javier. And let me also say it's an honor to share this virtual dais with all of you. So thank you for this opportunity. In terms of the lessons, as you mentioned, from what we've learned from 15 years at HITAP in Thailand, I'll highlight just a few. To start with, I think the most important thing is to get started. It's important for priority setting institutions to not necessarily wait for all the stars to align, but to at least use what is at hand and be able to demonstrate the potential policy impact of HTA or priority setting activities. So there might be windows of opportunities, such as implementation of a universal health coverage program, showing political will in that respect, or as an organization or as a team, you might have the ear of an influential champion, policymaker. Either way, it might be a way or an opportunity to really get the idea of priority setting on the political agenda and to help really push forward priority setting in health decision making as well. In some cases, this might not be available. And so one lesson we've learned is prepare so that when that opportunity does arise, one is well positioned to utilize or seize it as well. The second part is to really build a team and to build partnerships. You highlighted that as well in your lessons overall. Central to any HTA or priority setting work will be the people who are involved. And what we've learned is that skills can be learned or taught, but what can't be taught is having the attitude and the willingness to learn as well. And as we say, having a public mind as well. So that is a value that is important for us. And this might be different for different countries, but that's what one may want to look for. The other thing to keep in mind is that when one has a good team in place, funding and other aspects of work will follow. So it's really important and helpful to focus on building or identifying that core team. The other element of this is that one may not want to expect to do everything alone, and it would be helpful to really be open to partnerships and really to build and invest in these long-term networks. As you also pointed out, there will be enough and more work for all different groups, and there will be opportunities for everyone to contribute. And this is something really we've also learned from Thailand's universal health coverage program itself. The third is a less savory part of the process, and that is about planning and managing human resources in a way that is strategic. The reality is that people will move, and so one should be prepared in advance to really make the most of and retain staff while one can. Those that one, as an organization or institution, HTA or priority setting institution, one may have invested in. There may be opportunities to provide professional development and growth opportunities. And even if people do move, find ways to connect and maintain a healthy network, because ultimately we are all working towards the same goal of providing better health. The fourth point harks back to your point around how to link back with the broader stakeholders. And so it's important really to invest in communication strategies for different stakeholders, whether they are policymakers for whom clear, actionable recommendations need to be developed, or for the broader public who might need to understand in more simple terms what are the consequences of this process. In this way, the message will really outlive any single individual or even organization. So this is really key even from the start of an organization. And then finally, to say that it's important to learn, be flexible, and be able to adapt. We are in a very different place than we were, say, 15 years ago. The HTA and health landscape in countries and globally is more dynamic and exciting. At the same time, it might also seem a bit fragile. So being able to adapt and utilize the resources that one has in hand and embrace these changes will be important. And so as organizations, we will need to adapt and be more nimble as well. So with that, I'll pause and hand it back to you, Javier.
Thank you very much, Sotomini, for summarizing 15 years or in 1 minute or less. Very important questions, very important answers in terms of the key top of mind messages for those who are interested in pursuing priority setting and health technology assessment. Now let's move to Latin America. Latin America has not been part of the iDSI network, but it's clear how some of the challenges are similar and some of the solutions have actually been similar as well. So Ursula, what can you tell us about the lessons learned in terms of building and reforming institutions in the Latin America region?
Thank you so much, Javier. First of all, happy anniversary to iDSI. Actually, Latin America has had some support from the pre-iDSI stage of many of the people that participated in the early years. So we have benefited from it too. And then second, many thanks, Javier, for having me part of this wonderful panel from distinguished colleagues from all over the world. It's been really nice to have these different regional perspectives. As I have only very few minutes, I'd like to use 3 words to describe the current status of evidence-informed priority setting in Latin America. Progress, and I won't go into this, how much progress has been made and how HTA has been increasingly institutionalized and so on. Heterogeneity, as everything in Latin America, whenever you talk about Latin America, we talk about heterogeneity in all social and economic aspects. That also applies to evidence-informed priority setting. The majority of evidence-informed priority setting is very heterogeneous across the region. There are some countries that do not use evidence at all in their priority setting processes. Some use it ad hoc and some use it in a systematic way. But what interests me most to share with you are the 5 aspects that I think that need to be improved to better harness the potential for evidence-informed priority setting in the region. And I think they complement nicely what both Sotomini and you have said, Javier. And again, let me use words. So one word is pragmatism. The second word is opportunity cost. The third word is linkage. The fourth word is showcasing. And the last one is bird's perspective. So I hope I keep your attention with these 5 words. So pragmatism, I think we very often lose sight of the needs of policymakers. And I think that specifically in Latin America, evidence should really be adapted to fit the purpose of policymakers. Policymakers won't be able to wait for days and days and months to wait for the perfect report. The perfect is often enemy of the good, so more pragmatism is clearly needed. Also, doing always the full report is not a wise use of scarce resources. It's not always necessary. The second one, and this one is really close to my heart, interestingly, and this might surprise you when you come from other regions in Latin America, the use of the cost effectiveness analysis, and by consequence, the idea of opportunity cost, evidencing opportunity cost of tough decisions, is not something that is being used as business as usual in the evidence-informed priorities setting processes in the region. That's all the more worrisome because Latin America still faces important challenges in terms of health status, population health status. So this is something that really should change if evidence-informed priority setting in the region is meant to have more impact. The third one, and it is closely related, is linkage. There have been HTA institutes built in the region. There have been departments. There has been some sort of institutionalization, but anchoring HTA activities into legal frameworks and anchoring the use of these core criteria, among others, but these core criteria of cost effectiveness in legal frameworks is key. The fourth one has already been mentioned to a certain degree by both Saudamini and Javier, which is showcasing to policymakers all the time the benefits of evidence-informed priority setting, not only at the start, but all along during the process. But as long as you don't provide clear evidence on the benefits of all this, people won't support you, policymakers won't support you, policymakers won't fund you. It will be just a dead-like institution. And the last one, and that's something that I think that is very important and that hasn't been discussed widely, at least in the global health agenda, there is this idea that evidence-informed priority setting is basically overlapping with HTA. And I think we should change that perspective, because in order to make evidence-informed priority setting, you do not only need pieces of evidence on HTA, and even less so only on marginal incremental cost effectiveness or incremental benefits and costs, and even less so only incremental focusing on medicines. So there is this need to increase the scope of evidence-informed priority setting in our discussions. And I'm thinking there are many dimensions, but I would like to share with you two dimensions where I think there is really room to broaden the scope. One, costing information. Costing is not on the agendas, and costing is just as important as learning about effectiveness of interventions. And in Latin America, costing information is very limited. It's not a sexy issue, but it should go back on the agendas. And the other one is having information on the effective access to basic interventions, downstream interventions that might be included in health benefits package or in coverage lists, whatever, but it's on paper. I mean, that's completely different from what you see in let's say, Switzerland, where I am from, where you basically, it's okay to decide on the margin because basically you have access to all the basic stuff. But in Latin America, it doesn't make sense to only focus on the margin if you do not have effective access to further downstream interventions. And even if you think about opportunity cost, you shouldn't look only at the margin. So these are my 5 recommendations on how evidence-informed priority setting might improve in Latin America. Thank you, Javier. Back to you.
Thank you very much. So 3 words to describe the status quo and 5 words to describe what we should be doing differently. A lot of food for thought. So thank you very much, Ursula. Now let's move to the policymaker, and the policymaker who's not within the health sector, but is actually at the Ministry of Finance. So Mark, you've heard what, Saudamini, what Ursula said about windows of opportunity, about how it's important to establish linkages, implementation, a lot of different suggestions and lessons learned. How do you see priority setting from where you sit, from the Ministry of Finance? You get a lot of health officials asking for more money, asking for budget increases, and we all know that the situation is tight. There's a fiscal crisis, and oftentimes it's not do more with more, but do more with less. So over to you, Mark.
Okay, thank you very much, and good afternoon to colleagues from all over the world, wherever you come from. I must say, 10, 15 years ago, I didn't know what health technology assessment was. And so, I learned from many of these colleagues who are here, and I found that increasingly I had to learn these functions and do these functions. And now it's become clear to me that this is almost one of the most important things. So from a Ministry of Finance perspective, health departments tend to be the most difficult department. The health departments bring such complicated interventions. And I remember in an earlier part of my career, for example, we were asked to assess for funding 2 new child vaccines, the pneumococcal vaccine and the rotavirus vaccine. And here we were sitting in the Ministry of Finance, and this was going to be over R1 billion to introduce these new vaccines. And the work had not been done technically. I must say it took me almost a year to do the HTA because it had not been done internally. So, we had to virtually learn how to do this and do it in the Ministry of Finance. And it was a fantastic experience at the time. But after doing it a number of times in the HIV space and more recently in the COVID space, one gets to learn that actually the Treasury cannot be the home of HTA and assessment of this, and that you cannot assess these complex interventions unless somebody has done it. And so increasingly from the Ministry of Finance side, we have been telling our Department of Health, develop these institutions, and we are actually not going to consider your budget bid on A, B, and C unless you have done your HTA assessment on these interventions. So recently, for example, we had a budget bid for hepatitis C treatment agents. We thought really, these things needed to be funded. But we said to the Department of Health, we're not going to fund these things until you've done your HTA assessment. So increasingly, we're sending it back because we see this kind of complex analysis needs to be done. So as a Ministry of Finance, you can either give the Department of Health a broad envelope and then they make all the decisions. But what tends to happen is the big decisions, which cost, for example, billions of rand, they inevitably come back to the Ministry of Finance. And so, you really want to be comforted in the Ministry of Finance that a proper HTA has been done and proper assessments of the new technology. So it's become increasingly apparent to me in the Ministry of Finance that this kind of analysis is absolutely essential. And we really demand it routinely now. Back to you, Chairperson.
Thank you, Mark. It's great to hear that you now demand this type of analysis routinely and is now a prerequisite for making decisions. We will keep talking about Africa, and now we're going to invite Justice Novignon. Justice, you've been working, with African governments over decades on priority setting. Why do you think it's important to do this now? How do you link this to universal health coverage? Do you see the window actually opening up? Over to you, Justice.
Thank you so much, Javier, and thanks for having me. So Africa, like any part of the world, face resource constraints, and that is basic. The difference is that we face severe resource constraints, because of the growing, perhaps even tripling burden of disease. Communicable diseases are so very high. We have the growing burden of non-communicable diseases. We have a huge population in Africa actually suffer from neglected tropical diseases. And then, of course, now we have the emerging and re-emerging conditions. The COVID-19 is just one. Africa CDC tells us, for example, that in 2023 alone, they have had to respond to more than 160 different health threats across the continent. So these are growing. But we also know that this comes, in the context of not so much growing, maybe flattening, domestic financing. Financing from countries' own, growing, but not as growing as we expected, not from the country's own resources. We see of course, we continue to see that many of our countries are financed mainly by development assistance, but that fluctuates, and in many countries that is reducing. In all of these, African countries have developed, and rightly so, very ambitious universal health coverage roadmaps. Roadmaps that would see them expand significantly, hopefully, coverage of essential services to the populations and those that need them the most. So that is good that countries actually have a roadmap. Now, beyond having a roadmap, that happens to be ambitious. What do you do with a resource challenge? You know, we know that donor financing is going to keep going down, and it's going to be fluctuating, because if you depend too much on people, of course, they have to prioritize themselves first. So you always are not first. You always are second. So when something happens, you might be in trouble. That's why it's important for countries to themselves, pool their own resources. But those resources are limited. Countries want to implement so many things. We've seen many of our countries, for instance, recently, I think over the past 2 years or so, the number of African countries that have introduced social health insurance is growing. And that is a good thing, because it means countries now have a way of channeling more and more some of their own country resources. However, that is not the answer to all of this. And what am I driving at? The context for HTA over the past 10 years in Africa, we've seen that a lot has changed. In terms of the policy context, we've seen there have been a lot more policy awareness, thanks to the work the iDSI and other partners have been doing. But that policy awareness is usually still concentrated within the ministries of health. I mean, as I listen to Mark, it's a fantastic job you are doing with the treasury there. But in most of the treasuries in Africa, they don't even know much about it. They simply sit and expect that the ministries of health would actually find ways of showing that the resources are being used efficiently. So I think we've done a lot in creating policy awareness within ministries of health, not so much in finance, which presents an opportunity for us. We've done a lot in evidence. I mean, the iDSI and other partners and other, people really have generated a lot of evidence. If you go to places like Ghana, where now the HTA Secretariat tends to generate evidence based on the request of the health insurance scheme, for reimbursement, that is positive. So a lot of that is happening, and I think that's a lot of that also through iDSI. But we see some capacity increases in many countries, but that is a place that we can actually do more to contextualize the capacity, to localize the capacity, and ensure that we reduce dependence on external capacity when it comes to HTA and priority setting within countries. This is a place where we cannot, where plug and play doesn't always work. The way it happens in other countries may not necessarily happen in Africa. And finally, it is important that as we look for the next more than 10 years of evidence-informed priority setting growing in Africa, it's also important that partners, and I'm talking about funding partners, I'm talking about technical partners, have measured expectations. I have seen a lot where funders and technical partners have expectations sometimes that are unrealistic. That a country picks and institutionalizes HTA and starts making decisions with evidence within 1 year or 2 years or 3 years or 5 years. We need to allow the countries to do things at their own pace while we support them to mainstream. Things don't change as quick as sometimes we partners expect them to change in the countries. Know that the context is completely different, and be patient. Otherwise, we put so much pressure on the systems, and whereas pressure is important, too much pressure been a lot of improvements in HTA. Now developed ambitious UHC roadmaps. Those roadmaps actually need now more than ever evidence-informed priority, because we don't have all the resources. We need to find a way to be more efficient in what we do. Over to you, Javier.
Thank you very much, Justice. You have highlighted how long it takes and how much effort is needed, and the importance of being clear on what the expectations are going forward. And we'll get into the future in a minute, but before we do that, let's go deeper on the universal health coverage angle. And for that, Toshi, do you want to tell us a bit about how UHC links with priority setting and whether that has been considered as part of this new UHC financing hub spearheaded by Japan? Over to you.
Am I audible? Yes. Okay. Thank you, Abiel, and thank you for inviting me to this wonderful panel. And also congratulations on the special issue on the health systems and reform on priority setting. The editor-in-chief, Professor Michael Reich, is my mentor who taught me health system strengthening and UHC. So I'm also very grateful for that development. And just to give you some global health angle, let me just try to start this. Yes, so my name is Satoshi Ezoe from the Foreign Ministry, but I'm originally from the Health Ministry, basically knocking the door almost every day of the Finance Ministry. So I could resonate very much with the colleagues' wonderful interventions. But from the global perspective, Japan has been prioritizing global health in the diplomatic agendas. And within that, we have two major goals. One is to address the global health architecture for PPR, prevention, preparedness, and response to pandemics. But the second major goal is to basically sustain and achieve and sustain UHC around the world. And we have used different global forums, including the G7, G8 summits, to really highlight global health. And in recent years, especially on universal health coverage. So we were one of the vocal advocates to include UHC in the SDGs. And also we have been conducting high-level events to highlight UHC. And for example, in 2019, when we hosted the G20 summit in Osaka, it was the first time that we have convened a joint meeting of the health and finance ministers to specifically discuss health financing for universal health coverage. And we have also together with the other member states, we have managed to convene the first UHC high-level meeting in 2019, right before the COVID. And after the COVID, with the overall goal of universal health coverage, we embarked on COVID-19 cooperation as well. But coming back to the universal health coverage, so we hosted yet another G7 summit last year. And towards that, the Prime Minister Kishida contributed a vision article on the Lancet. I was one of the co-authors, the drafters of this piece, but the essence is reflected in the title. So human security and universal health coverage. Again, we advocated for, now that COVID-19 is settling down, we thought 1 year ago that it is time that we refocus our attention on the long-standing health challenges under the umbrella of universal health coverage. So that was the key message. And under this overall vision, we negotiated with other G7 members, and they came up with the summit declaration. And we formulated our health outcome document in three ways. One is to address and strengthen global health architecture, but the second one is to achieve UHC. And the third one is to address through health innovations. And I will not go into detail. I will come back to your original question on the UHC Knowledge Hub. But this is the one-page summary of the outcome, which is also elaborated on the G7. The Lancet piece. I would just like to pick up from among those outcomes. I just want to pick up two relevant initiatives. So one is, as you asked, Javier, the UHC Knowledge Hub idea. So that was originated from our long-standing kind of advocate for achieving universal health coverage, including in developing countries. And so this idea came in the context of G7 first. So last year, the G7 leaders noted the importance of creating some kind of global hub related to UHC. And it has kind of developed. It is still a work in progress. But this year, so the government of Japan announced our intention to establish a UHC knowledge hub next year, in 2025. It was announced at the World Bank's spring meeting by the finance minister, as well as at the World Health Assembly by the health minister. And so the idea, so if you look at the bottom, this is still a work in progress, and we are in discussion with mainly with the WHO and the World Bank, but also with other partners. So the idea is to collect and share knowledge on the UHC, including health financing and others, and also capacity building for finance and health authorities in developing countries, and try to utilize Japan's knowledge and experience. Of course, as our colleagues just mentioned, context is different in different countries, so we cannot do like a one size fits all approach. But Japan has its own experience on managing UHC for half century and more, and we are faced with the aging population, for example. So we could maybe contribute from the knowledge point of view, besides financing. So we have been convening health UHC forum, but in the context of UHC Knowledge Hub, the idea is to convene likely every year to different leaders from different countries and organizations to discuss how to advance UHC. So this is a rough sketch at this point, but it is very timely that I am in this panel to learn from you on how to kind of try to incorporate the very important area of priority setting in the context of achieving UHC or sustaining UHC. Just one word on another potentially relevant initiative stemmed from the G7. Which is called, as you said, Future. The initiative was called Future of Global Health Initiatives. So as you laid out in the beginning, the last kind of key takeaway was to align the national priority with the global health initiatives, as I understand it. So this is in that context, this may be relevant. This was spearheaded by the co-chairs from Norway and Kenya. And the idea, the basic idea, this is an ad hoc initiative, and the purpose was to identify ways to ensure global health initiatives. In this case, we were mainly thinking about the Global Fund, Gavi, UNITAID, FINE, GFF, and CEPI, but potentially more. And so those major GHIs, to ensure that they are more effective, efficient, and equitable in complementing domestic financing to strengthen health system capacities and deliver health impacts as part of country-led priority setting processes and trajectories towards universal health coverage. So basically, the idea is to try to align among different global health initiatives towards the common goal of achieving UHC in country. And we have after consultations with different stakeholders, we came up with this Lusaka agenda late last year, which outlines some key principles. And it is a work in progress, but it may be relevant as we go in the context of priority setting agenda. And again, so this Lancet piece is kind of like a blueprint for, in our view, for the future kind of direction on global health. Of course, it is upgraded and the situation is changing, but if you're interested, please go over. And let me stop here, and I look forward to further discussions. Thank you.
Thank you very much, Toshi. To our audience, please submit your questions now using Slido or using the link in the YouTube chat or in the event webpage, and we'll basically get those questions to our panelists. But before we do that, I just have a question for you all. I mean, we've said, it is very important to build institutions. It is very important to make decisions informed by evidence. But it's clear that it takes time, that is difficult, that we have resource constraints. So looking at the future, how can we better position, priority setting in the current political and economic environment? In other words, what can you say about why priority setting now? And let's start with Sadamini. If you can just give me a couple of sentences, so very short, so we can take questions from the audience. Why now, and how can we position it better? Sadamini, over to you.
Thank you. I think we are just out of a major global crisis. And as we know, every crisis also presents an opportunity. And this is one where we can really look at our systems and rethink ways that we can do things so that it's not business as usual. We've heard from other colleagues as well. We are in a period of restricted finances, a need for contextual support or solutions that can be advanced. At the same time, be able to draw on networks that have emerged regionally or globally. And this is as good as any other turning point for us to then look at implementing priority setting. Because as some wise person has said, it's never too early to implement priority setting until it's too late. So this is a good time for us to relook. Over to you, Javier.
That was a very nice sentence. It's never too early, but it might be too late. Ursula, what are your reflections on that question? Why now?
Maybe what I would like to share with you is that I think most of us, and I guess the audience, we are all aware of why evidence-based priority setting is more relevant than ever, and that much is at stake. And there are the old kids on the block, and there are the new kids of the block in terms of why it's relevant. But what I think we should really try to focus more on is that relevance and need is not enough to create demand for evidence-informed priority setting. So the question would be, what triggers demand for evidence-informed priority setting? And what are the kind of, let me call it, appetite stimulants and appetite suppressants or suppressors, that create that demand? And I have only some words left, but on the side of things that might create demand is of course the need that you provide fit for purpose solutions, that you showcase the benefits, that you grasp the windows of opportunity. That's something that several colleagues have said. And on the suppressor side, there are things such as blindness to resource limitations, which is a call to make the restrictions much more clear, at least in Latin America. That's a real issue. There's this policy evidence gap we have been talking about. And one thing that worries me is that the rising populism, because populism is not really a good fertile ground for evidence-informed priority setting, because emotions matter more than evidence, short-term is more important than long-term, complex issues are too complicated, so let's just simplify it. So this is not really promising, but I think that even under populist leaders or situations, we have to analyze the kind of opportunities there are for evidence-informed priority setting. And we have seen that in Latin America. Even during the COVID crisis, with certain leaders rejecting the evidence in the first rounds, later on, given the seriousness of the crisis, there was room to use evidence. So my point is, let's really think about what triggers the demand for more evidence-informed priority setting as a basis for positioning it better on the agenda, which is the question you ask. Thank you, Javier.
Thank you. I guess you are highlighting the importance of political economy and how it's not about relevance and need. It's not rational all the time. So thanks for doing that. Mark, what about you? What do you think about making the case? Why now?
Okay.
Here.
Okay, thank you so much. And first, let me just also echo the colleagues in congratulating the Center for Global Development and also the HSR journal in bringing out the special edition. I think it's really a fantastic piece of work. So congratulations on that. So I agree with Sodamini's point about in the COVID period, the post-COVID period, we see at least 55 countries in fairly severe financial distress. And it's really important in this time, in this period, to focus on the most cost-effective and essential health services, because otherwise, and many health ministers and health departments are quite exhausted after the epidemic. And in dealing with these tight budgets, when people deal with it in a bad way, they often really harm services. So giving attention to the most highest priority services, and one sees this also, for example, in the Global Health 2035, the DCP project, the importance of focusing on, if we're going to get maximized outcomes on the right things, this is very important. Then what we see is going away from COVID, many countries focusing again on this huge chronic disease and cancer burden. And some of these areas, for example, some of the cancer services are very expensive and new interventions. And so increasingly, we need guidance on how to proceed with this very, very important agenda, which is the major causes of death in the world at the moment. At the same time, as several colleagues point out, we're seeing a lot of countries emerging with health system reforms, new health insurance funds, new arrangements. And so we're seeing a lot of institutional development, and the development of HTA processes and institutions at this time to guide these bodies is very, very important. And we do see some very good and interesting examples. I mean, for example, in China and some of the other big countries, I mean, historically, all of us have learned from Thailand and UK and so on, but we see many new big authorities emerging in different countries. And I think it's really worth writing up those experiences because they're very inspiring, and some of them on quite a big scale. And I think increasingly at this time also to inform budget processes, both between departments and within departments, this is particularly relevant. So for me, those are some of the reasons why this is important at this time, Chair.
Thank you very much. So I guess I highlight the importance of using evidence-informed priority setting, not just to expand, but also when cutting. So when cutting, the importance of really protecting the most essential cost-effective services. So thank you, Mark. Justice, what are your thoughts on this?
Thank you, Javier. I would not like to repeat anything that colleagues have said, just add on. So let me turn the question back, Javier. Why now? Why not now? Why not now? Because we have seen the devastation that COVID-19 brought us. I'll say a bit about COVID-19, but from a bit different perspective than Mark. And people have asked me, why do we need evidence-informed priority setting during emergencies? We have seen, for example, that policymakers have been very reactive. When it came to COVID-19, I doubt many countries actually thought about optimizing resources. In fact, for many countries in Africa, the nature of spending and the lack of optimization of those have contributed to the economic mess we are in now. Of course, there are many other things that contributed. But it is important for us to always prepare. And I believe that this is a time to ensure that countries have a strong, priority setting processes. In Ghana, where I come from, we have an adage that says that if your neighbor's beard is on fire, you actually don't wait for the beer to burn, but you make sure you have enough fire by you so that when you prevent your beer from burning. COVID-19 was more like putting our hairs and beards and everything else on fire. And I don't think we need to fold our arms with respect to beginning to optimize resources, being efficient in our planning and use of resources so that we can better prepare both for the next emergencies, but also for routine service delivery. So for me, the call and the opportunity to make sure we implement EIPS is actually now. And once that opportunity leaves, Esla mentioned there's a window of opportunity. Once it goes, it might be difficult for us to push that back on the agenda. Over.
Thank you, Justice. Toshi, what are your thoughts?
Thank you. This has been very inspiring. So why now? From the perspective of so-called donor, so we have spent a lot domestically on COVID, but also globally. Japan has spent more than $5 billion just for international cooperation on COVID-19 through bilateral and also multilateral. But as others have been saying, there are growing other important global issues like climate change, geopolitical issues, food security, and so on and so on. So I think we have already entered into the phase of neglect when we think about the panic and neglect cycle. And so it is harder and harder to really convince finance authority and the stakeholders and general public to really convince to invest even more to global health. Japan has been prioritizing this, so I think we are relatively in a safer position, but we cannot do this as we have been doing. And otherwise, we cannot achieve UHC. So I think it's a necessity to really continue to try to achieve and sustain UHC around the world to set priorities. But just one more word. When you also asked about the global agenda setting, I have been doing that for the past few years. Or about 10 years on agenda setting in global health around UHC and others. My question to the panel and maybe the audience that I have been kind of grappling with when I think about how to frame this as a global health agenda or global agenda. Priority setting as a policymaker, this is a very important thing, and this is almost what we are doing every day. Priority setting in every sense. But when people hear, especially from developing countries, when you just bluntly say, "Okay, our now priority is a priority setting," people might wonder, "Okay, then what area would be cut?" And okay, so does that mean this service will discontinued, or this project from donor X will be discontinued? So it could kind of trigger some worry, I imagine. So while this is a very important and technically very sound area that I can understand from the technical point of view, but from the global policy and political perspective, we may need to think about how to frame this agenda, rather not to create such a kind of unfortunate image that it will basically cut some services. And this has to be also in line with the basic notion of SDGs, leaving no one behind. Of course, it can be coexist. It can coexist, and it is not. In order to leave no one behind, we need priority setting. But we need to have a better narrative to really address such kind of image. But I don't have an answer to that. So for now, so just wanted to lay that question out. Thanks.
I think that's a very important reflection and an important point that we should all consider when discussing priority setting. I'm coming to the end, and I've got a few questions from the audience, but I will read 2 questions from the audience, and I will ask you all to, give me a short answer and or your takeaway messages from this conversation so we can close on time. So the 2 questions that I have prioritized is, one is to some extent related to what Toshi said. Sometimes priority setting tends to be about easy to reach population leaving behind the most vulnerable. How does evidence inform priority setting and the relevant tools avoid increasing health inequities? And the second question is, with HTA being done more than ever, how might countries better cooperate with their peers and neighbors to avoid duplication of efforts and draw synergies? So with those 2 questions, and please keeping in mind your takeaway messages from the session, let's start with Saudamini again, please.
Thank you so much. On the first point around whether HTA or priority setting, how it interfaces with equity, it's really important. And in fact, I think the most recent definition of HTA also tries to incorporate equity. So it's not only a matter of efficiency. And this is why we often say that HTA or even other types of research is being used to inform policy, not necessarily be the sole basis for making a decision. One way in which we do so is to have a deliberative process so that we are able to incorporate these other considerations into the decision-making process for health. So it's not only about cost effectiveness, but other elements too. So that's one. And increasingly, we now have methodologies like distributional cost effectiveness analyses or other methodologies that can help us really look at this analytically and help support the discourse using evidence as well. So there are exciting opportunities on this front to be able to address the issue of equity. On the second point about how we can reduce duplication, this is another area of opportunity going forward. I think in the Asian region, a few years ago, I think when we talked about harmonizing HTA, like the European Union, we said Asia is so diverse, we don't think it's still feasible. But now we are, in fact, in the ASEAN region, for example, we are looking to harmonize our HTA practices, starting with having a common format for clinical reporting. And we are hoping, again, that given a lot of similarities, we can actually come together, utilize our respective strengths, and reduce duplication in efforts. So this is, again, another area of opportunity for us, and we hope we have some lessons to share with you going forward. Over to you, Javier.
Ursula?
Thank you, Javier. On the equity question, I couldn't agree more that we should take this into account, and there are some good methodologies out there to do it. But if I'm completely honest with you, in Latin America, there is basically almost no country that would have the data to use these tools. So I think we have to think about ways of incorporating the equity dimension in a very pragmatic, less than perfect way, given the information that is around. And the second point I would like to raise is connected to Dr. Toshi's question about how to frame this. I think that we should really start to make it much clearer that evidence-informed priority setting is not about cutting budgets. It's about saving lives. And this leads me to one of the first points I mentioned, illustrating how evidence-informed priority setting can reduce the opportunity cost of decisions, talking in technical terms, and thereby save lives of the population at large is something we're not using very much. I mean, we always refer to the 93 report and some Lancet articles, whatever, but at the country level, that's not being done. And then with regard to the duplications, I think, and this is something that many experts in HTA will not agree on, but I honestly don't understand why so much money, so much effort is going in developing countries, in middle-income countries, into evaluating, let's say, the last treatment with a really bad cost-effectiveness ratio in England, Germany, and no, Germany doesn't do that, but England, France, Australia. Why would we do that again? Why don't we focus our scarce resources on HTA issues that really matter to our countries? So I would leave it there. Thank you, Javier. Back to you.
Thank you. We are at time, so two sentences from each of our three panelists. So Mark, 2 sentences, Justice, 2 sentences, Satoshi, 2 sentences, and we'll close. Mark, over to you.
Well, just to say that, I do think, given its HTA's importance, that we need to think about increasing transparency of HTA reports so more people can access them. Certainly when we've done them, we've had to search publications to try and get hold of them. But just in closing, to say how important HTA is becoming for us as a Ministry of Finance in assessing new health interventions. So really to encourage health departments to develop the institutional structures and the HTA processes to properly evaluate their interventions. Thank you very much.
Thank you. Justice?
Thank you so much. So my first conclusion would be that priority setting is not only limited to countries. Priority setting should also be practiced by funders and by global health institutions. And I look forward to the day when a major funder will tell a global health institution that, look, like Mark said, before I put money into this area, I want to see evidence that this makes economic sense. Finally, the duplication is one of the reasons why a regional approach to priority setting or tapping into regional platforms. I mean, in Africa, the Africa CDC began to pull together some platforms. So when multiple countries pull themselves together to work towards helping each other, they then are able to see how to together eliminate, duplications and learn from each other to inform what they do. Over.
Thank you. Toshi, you've got the final word.
Yes, so the time is technically up. So I just want to thank you for very rich discussions and food for thoughts. So as we prepare for setting up this UHC Knowledge Hub, we will try to consider how we can address this important question of priority setting and how we can kind of move this forward as a global agenda. Thank you very much.
That's a very nice way to finalize this conversation. Thank you to our audience. Thank you to our panelists. It's been a very rich and fruitful conversation. Please do read the articles in the HSR special issue and do read the project page where we've got testimonials and lessons learned and everything else. And thank you all very much. Have a good day and we'll see you very soon. Bye-bye.
Bye. Thank you.
Thank you.
Bye. Thank you.
Thank you.